Welcome to GU Oncology Now. My name is Brian Myre. I am a GU medical oncologist with the Moran Cancer Institute in Chicago. We have a great roundtable here to discuss prostate cancer, systemic therapies, local disease, advanced disease with urologic oncology, medical oncology from the Chicagoland area. We'll go down the list and have everybody introduce themselves, and then we'll get chatting about prostate cancer.
I'm Dr. Andrew Wiele. I work at the Endeavor Health Cancer Institute, primarily out of Elmhurst Hospital in the western suburbs of Chicago.
Dr. Ranko Miocinovic, GU Oncology at Moran Cancer Institute.
My name is Amit Patel. I'm a GU oncologist at Moran Cancer Institute, Dooley Health and Care.
Hi, I'm Dr. Ashley Ross. I'm a urologic oncologist and professor of urology at the Northwestern Feinberg School of Medicine.
Hi, I'm Dr. Alan Wan. I am a medical oncologist at Dooley Healthcare, Moran Cancer Center.
So I appreciate everybody joining us. We'll get started. Prostate cancer has evolved a lot in terms of therapeutics, diagnostics, biomarkers. I think it creates a lot of interesting discussion and decision points for patients. So we'll just kind of, lay out how we treat patients, let's say in the intermediate risk category where we have a patient based on PSA or maybe biopsy grade group. What are we doing next to work up those patients? What tests are we using? Where are we going? Maybe start with the urologist.
Yeah, I'll kick it off. So, for our intermediate risk patients, particularly once you get to unfavorable intermediate risk, that's a category where we have high level of evidence that local therapy improves survival. And the reason local therapy improves survival in there is that they sort of cross towards this threshold where the disease, while localized or presumptively localized, has at least the capability in some cases of metastatic spread and to cause meaningful outcomes. And so that's sort of a line, like as you get to, let's say, NCCN unfavorable intermediate risk, or if you use the American Joint Cancer Commission staging like stage Roman numeral 2C, that you're going to want to understand, is this disease actually clinically localized? And maybe how aggressive it is, because you're really thinking about treatment as opposed to surveillance categories. When we're thinking about the staging, most of the people that are coming through our practices as urologists have already had an MRI prior to their biopsy, both for its negative predictive value to see who doesn't need a biopsy, and also for its positive predictive value to help us with an accurate sampling of the prostate. But you want to do a whole body staging, and now for several years, most of us are reaching towards PET PSMA imaging. Some people are still not staging all unfavorable intermediate risk disease, but if you look at them as a category, Gleason grade group 3 and above, even with PSA under 10, or certainly 2 unfavorable intermediate risk features, you have between 5 and 15% of patients having disease outside the prostate, whether it be N1 or even M1 disease. And although there can be some discussion that we can all have about, what does it really mean to have low volume metastatic disease in the PET PSMA era with that definition that might be unconventional imaging, M0, for a lot of us as clinicians around this table, we want to know if you have, M1A disease, M1B, or even N1 disease, even defined by PET, so we can counsel the patient appropriately and go through management strategies. So it's usually we start with at least staging of those people, and at least in my practice.
That's a good question about the PET scan. If you have an intermediate or even a high-risk patients where conventional imaging does not show a lymph node, and then you have a PET scan, and you have activity in lymph node. If you go back to like the Stampede study for high-risk patients, we were using conventional imaging. Now we have patients who are upstage. So should that change our treatment for those patients? I always order PET scans, unfavorable intermediate risk, a lot to look for bone metastasis, but we get these situations where we have a node positive. So it creates a question.
There's one more thing I'll say, and then I'll sort of defer to my other urologic colleagues, is, one negative is as you go down in risk to that unfavorable intermediate risk where the pretest probability is like 95% chance we're not going to see distant spread, you start to butt against the false positives that can happen in the PET PSMA scan, because prostate-specific membrane antigen is great, way better than just looking at size of a lesion and stuff, but it's still not fully specific for prostate cancer. There could be aberrant bone uptake, ganglia uptake, et cetera, and it can cause some consternation for the patient if you do dive down a rabbit hole with them.
Yeah, absolutely.
Well, I think I agree 100% with everything that Dr. Ross has said. I think that is the most interesting category in prostate cancer management when it comes to localized disease, is this intermediate risk. High risk, we sort of know what to do. But I think this PET CT experience, I think, is important as a surgeon to know, because you can have positive rib lesions, which we know are false positives. And you can have some other things positive, but if you're used to seeing these images and operating these patients, eventually you get a sense of what you can operate on, what you can't operate on. And I think I've gone both ways, where you can, sometimes PSMA PET shows a positive note and it's negative with final path. Sometimes it's negative with PSMA PET, but it's positive path. But I think PSMA PET is a part of our everyday practice, I would say.
And I wonder, for the medical oncologist like yourself, if we take that case example, and let's maybe even be more provocative, that the PET finds a bone lesion that, pretty PET avid, mildly sclerotic, and say we're even not sure because the guy was 437 coming in, and we do a bone biopsy that shows they are by PET, but maybe conventional imaging, because you get it and it's bone scan negative, nothing really leaps out at you on the MRI, but by biopsy now it's proven M1B disease, would have been too small to find in those old series, like you said. The question is, what do you folks do to tailor your management of that, individual? Do you sort of say, well, conventional is negative, we're going to treat you that way, or what do you do?
Absolutely not. I mean, we have confirmed histologic disease, and sometimes these PSMA PET scans can create a little consternation for both the patients and the physicians, but I think it's better to know than to not know. And in that situation, unfortunately, the PET scan revealed what we feared, but ultimately is still best for the patient to treat them accurately.
Yeah, and what I fall back on is in Stampede, that we were sort of, I think we mentioned a little bit, a multi-arm trial from the UK. There was data that came out of that, and data that we already kind of suspected from other trials, that they're doing something to the primary. It's primarily been radiation, but doing something to the primary in the setting of low volume metastatic disease is helpful for a few reasons, whether you believe in local control for symptomatic control, or whether it's like seeding of future metastases. And so even that guy who's M1A or M1B, and even nodes out of the pelvis or bone out of the pelvis, if that's a very fit man, you don't have to deny them opportunities for local control. And then there's other evidence that comes and now is kind of being studied in trials, like the ECOG group has the ADREAM trial, that like if someone does exceptionally well and you're treating them as low volume disease on conventional imaging, you can peel back, therapy later. Yeah. So it gives you some laterality.
I'd like to just go back a step or two. So with unfavorable intermediate risk disease, I get the sense we're not getting conventional imaging for these patients anymore. We're jumping straight to the PET. It's amazing. For a lot of them, because they're getting the pelvic scans, prior to the biopsy, and so you have that scan, and we're not doing the CT to look at the upper tracts or to look at the retroperitoneum, and we're instead getting a PET PSMA.
I would completely agree. The pro-PSMA study way back in, I think it was in Australia, was looking at, conventional imaging approach versus which we call it now older imaging approach, versus PET PSMA. And it showed that if you're omitting the bone scan and going the PET PSMA route, you're getting less radiation and more accurate results. And so then we looked at our Northwestern series, and it's exactly how you practice. We're now going, first step is, diagnosis, and then if they need staging, PET PSMA is first, and the other imaging is used to maybe adjudicate an outcome, not as the primary way. And I think that's what's happening nationally, and I'm not sure what's happening in your institutions, but the thing that's come from that is, a little bit of access issues for the patients and getting in for the scan, and then there's been also all these readers who were maybe reading FDG before. There's nuances to these scans, and luckily, what we maybe consistency is an issue, and what we're seeing coming down the horizon, which is exciting, and is somewhat already, there are some things that are already out there, but not heavily utilized, is big opportunities for AI. And I'm sure we'll talk about it later, but it's not just a nuke med has to read the scan, But if they have advanced disease, and certainly in the castrate-resistant setting, then you folks want to know, what's their likelihood of responding to therapy? What's the SUV? If you do something to them and you get another PET scan, it's like, what's the changes? It could drive people crazy without the AI, from the localized thing all the way through.